It's really a pleasure to be here today. It's just great to see all the interested folks here. And what I'd like to, we're going to talk about mainly what we do in the emergency department, but as you'll see, as different speakers come, there really are recurrent themes. And one of the things that I found when I'm trying to teach this to our staff, you have to repeat these things about 3 times. I think that's what most adult learners need. And I think you'll see that we'll have some recurrent slides and themes today, but I think that will help us to really take this material home. I'd like to just tell you a little bit about our medical center, Ridgeview Medical Center. We have a hospital in Waconia, Minnesota, which is just on the outskirts of the Twin Cities. It's a 150-bed community hospital. We do have a full ICU, and so most of our severe sepsis patients are admitted to our hospital, although some do require transfer to a tertiary hospital for some specific instances. We also have a freestanding emergency department in one of our suburbs in Chaska, Minnesota. And so we don't have any hospital beds there, but we have a full functioning emergency department. So we will stabilize patients there, and then we'll transfer the patients to an ICU. We really have 2 perspectives. One might be a bigger hospital perspective, and one may be a little bit of a smaller hospital perspective, in that we do have an ICU in one and one not in the other. One of the things that has really been a challenge for us is really to try to get our staff to really see sepsis as a true emergency. And as Dr. Evans had mentioned, and it's happening, but it's taking some time. And so, you know what, just like we have in our hospital, I'm sure many of you have protocols for STEMI and for trauma and stroke, which we've all worked on. Many hospitals don't have protocols for severe sepsis. In fact, the Minnesota Hospital Association did a survey of all the hospitals in the state, and of those who responded to that, only about 25% of hospitals had protocols. One of our goals here is we hope that every hospital will have protocols for severe sepsis. So the new paradigm, and this is a recurrent theme, is we need to really see an urgency. When patients come in and they're very sick and septic shock and fever, it's very obvious. That usually happens, but sometimes when patients come in with just not feeling right or weakness, you know, you look at your board and, oh no, I got to see another patient with weakness, and you maybe want to go take a break first. But you need to have that urgency that these patients could be severe sepsis. So what we're going to talk about, I'm going to go over just the recognition and screening of sepsis in the emergency department. We'll talk a little bit more about usefulness of lactate testing. I'm going to reemphasize the importance of early antibiotic therapy. And we're going to talk more about the 3-hour bundle in this section and talk about something called our transfer trigger tool. And then we'll talk a little bit about ED initiation of a 6-hour bundle, but there'll be much more detail on that later on this afternoon. And then Marcie's going to talk about some practical nursing tips that relate to all of these things. So first of all, recognizing sepsis. And I think one of the challenges that as we review cases, it's the patient that comes in with just nonspecific symptoms and doesn't have a fever. And it's the elderly patients. As you know, one of the reasons that we're seeing more and more sepsis is not only because we're recognizing it, but I think we're also seeing a shifting demographics, because sepsis is really a condition of older patients. And this just shows that patients, the majority are over 65. And you know, for acute MI in older patients, 25% of these patients don't have chest pain when they present. And I think about that same number of older patients with severe sepsis don't have fever. And so those are the ones that we tend to miss. So this is, you know, from the guideline. What I want to point here, I don't want to go over all these definitions again, but just to realize that some of the SIRS criteria, fever may be missing. Some of these patients might actually present with hypothermia in the older patients. And in addition to the SIRS criteria, altered mental status is a really big one, as Sherry just mentioned. And then some of the new things that are on the new guideline that were in the old one are things like plasma procalcitonin. I don't know if all hospitals can do that, but that is a test that we include as part of our initial lab studies. C-reactive protein. And so just to keep in mind, these are some of the other things that give you a diagnostic criteria for sepsis. But one of the things to remember is it says infection documented or suspected. Now, if you don't suspect infection, none of this works. So you have to always be thinking in patients who present with these really non-specific complaints, could this be sepsis? Could this be an infection? Again, this is from the guideline. These are the hemodynamic variables. And they've already been gone through, so I'm not going to go through a lot of this again. So just to reemphasize that fever may be absent. In fact, in one study, 13% of patients over 65 did not have fever, and compared to 4% of patients less than 65. And I've seen another study where even up to 50% of older patients may not have fever. They also may not have some of the other service criteria. They may not have tachycardia. They may not be able to mount that catecholamine response, or they may be on a beta blocker. They may not have hypoxemia. So infection may not be apparent, and again, the only thing that they may present with confusion or delirium, or other complaints such as weakness, falls. Syncope is I think I've seen a number of patients present severe sepsis when they just come in with syncope. And then patients just coming in with incontinence or just not eating. So as far as, I want to emphasize the importance of recognizing sepsis, but recognize it in those patients where it may not be apparent. Again, this is just kind of a summary, again, of just some of the things that Sherry just went through. Altered level of consciousness, lung injury. One of the things I want to point out is we see a lot of patients who come in and they all get troponins, right? They get EKG troponins there, and they have an elevated troponin, and all of a sudden everybody thinks this is a cardiology patient, that they need to go to the cath lab, or they call the cardiology for a consult. A lot of these patients with severe sepsis have myocardial dysfunction due to the severe sepsis, and many of them will have elevated troponins and elevated BNP. That may not necessarily mean that they have acute coronary syndrome. It's possible they could, but these are some of the things that you will see as well. The other one that I always like to point out, when I see somebody has a platelet count less than 100,000, that really gets my attention. So I look at the platelet count. So let's talk a little bit more about screening for sepsis. And this, again, is for the guideline, and this is something that I always emphasize, that the guideline says it's a strong recommendation that we screen patients, routine screening of all patients for sepsis and severe sepsis. And this is a grade 1C recommendation, which means it's strongly recommended. And there is good data that shows that early recognition of sepsis and implementation of early evidence-based therapies improves outcomes and decreases mortality, as we've already discussed. And this is, again, from the guideline. And I think this is a clear statement. All hospitals should have sepsis screening tools that should be utilized not only in the emergency department, but the ICU and the general medical ward. Now, this is an algorithm. I think you may have this in your handouts here. This is an algorithm that's developed by the Minnesota Hospital Association that really goes through the screening. I know you can't read this very well, and I'll kind of blow some of these things up as we go here. But this is, up here is the 100 rule we just talked about, and if they have suspected infection. So the top part just shows if they're being screened for sepsis. And so this is what constitutes a positive screen for sepsis in triage or up on the floor. In a patient with suspected infection and 2 or more of the following. So we have the 100 rule, but in addition to that, we also do add a respiratory rate and altered level of consciousness. So if they have a temperature over 100, heart rate over 100, systolic blood pressure less than 100, respiratory rate over 20, or altered level of consciousness, that constitutes a positive screen for sepsis. Then the next step, the response of the nurse should be then to initiate the evaluation for severe sepsis and septic shock. And at this point, we've empowered our nurses in the emergency department. They don't need to wait for an order from a physician. They will immediately place the patient in a room in a monitored bed in the ED. They'll start an IV, draw bloods, and they'll send off bloods for CBC, lactate, blood culture, UAUC, metabolic profile. And they'll get the physician involved, but they don't need to wait for an order for this. These patients get triaged very quickly. They get placed on a monitored bed. They get non-invasive blood pressure monitoring and oximetry. They don't just put a saline lock in, they put a liter of saline and they start running fluids in, and they notify the physician. And then in our hospital, we then will print off something called a severe sepsis septic shock checklist. It's because we always can't remember these things. We have to have a lot of help. And I'll show you that in a minute. So let me talk a little bit about the usefulness of lactate. Lactate is really a marker of bad things. It's an early warning sign. And we think this is very important. Again, in our hospital survey, we found that 25% of hospitals don't do lactates. And we want to make that 0 in the future here. But why is lactate important? Well, it's a little more complicated than this, but generally, when oxygen demand exceeds consumption, you get anaerobic metabolism, which results in lactic acidosis. It's probably also related to the catecholamine surges that you see. Lactate is mostly produced in the lung, in the heart. And so it's really a surrogate marker of global tissue hypoxia. A normal level usually is less than 2 millimoles per liter. over 4 indicates high risk for mortality, and so that's kind of the cutoff that we use in the guideline is 4. But really, any lactate elevation above normal is associated with increased mortality. So a lactate is really a marker of what we call occult severe sepsis or occult septic shock before you see the clinical symptoms, signs such as hypotension or altered mental status. So we really believe strongly that every hospital should be able to perform lactate with results within 30 minutes. And as I mentioned before, in this recent survey, of those responding hospitals, 24% of hospitals don't have the ability to do that. But I think we can change that. And this is, again, to quote Dr. Davis, who says, if a patient is sick enough to order a blood culture, then they're sick enough to order a lactate. And so many hospitals like we have, we link a lactate to a blood culture. So if we get a blood culture, they automatically get a lactate. When we put the order in, it comes in, and we have to actually cancel a lactate if we don't want it. So I just want to respond to a few questions that people have sent in about lactates. So first of all, how do you measure lactate? Well, first of all, it doesn't need to be an arterial sample. It can be a venous sample. You can use a tourniquet, and you just don't want to have long tourniquet times. That can sometimes give you a spurious result. Generally, we like to get the lactate off the first tube, as we draw bloods off a Vacutainer. You should put the tube on ice. I think one of the things that also does is it prompts the courier that this needs to get to the lab quickly. And most lactates are actually run on a blood gas analyzer. So what if my hospital cannot perform a lactate? Well, I think that there are things that we can do fairly inexpensively so that every hospital can have a lactate. In fact, several hospitals in the Minnesota region have got grants to buy iStats as part of the emergency preparedness grants. And iStat analyzer is one point of care testing that is fairly inexpensive compared to some of the platforms. Usually you can get that for less than $10,000. The other nice thing about the iStat, you can also perform blood gases on it. You can do electrolytes. It can be a backup for your platform analyzer. So if you don't have a platform that can do this, but many hospitals do have blood gas analyzers, and they often can do lactates as well. So if you don't have this, talk to your lab, and there are ways to do this. But I think this is the standard. Every hospital should be able to do a troponin. Every hospital should be able to do a lactate. Well, how about this? What can't we just measure the bicarb or the anion gap to see if they've got acidosis? And actually, no. The bicarb or anion gap can be normal in up to 20% of patients with severe sepsis who have a lactate greater than 4. So it's not sensitive enough. How about this? Does a normal lactate rule out a septic shock? And unfortunately, no. It's a good screening test, but it's not perfect. So you can have patients with septic shock that have a normal lactate. And this is seen especially in elderly patients who just can't mount that catecholamine response sometimes. And what are some of the other causes of lactate elevation besides severe sepsis? I think some of the things were mentioned. I think one of them is seizures. Sometimes if you get a lactate right after someone who's coming in seizing, it may be high. So again, it clears fairly quickly, as Sherry said, so you maybe need to wait 20 minutes for that to check that again. Certain drugs, beta agonists, if you have a patient coming in, they've gotten 3 nebs on the way in, that may raise their lactate. You may need to check it again. Certain drugs like metformin or cocaine. Lactate is about 80% cleared by the liver, so if you have somebody who has hepatic failure, their lactate may not drop as fast, or they may be elevated. And then, of course, ischemic bowel. Mechanism is a little bit different there, but that's, again, a marker of badness as well. So what do we do about the lactates that are greater than 2 or less than 4? And these patients are still at higher risk. They still require aggressive resuscitation, fluid resuscitation, and early antibiotics. They need to be monitored closely. This is a patient I wouldn't admit to the floor. I'd probably put this patient in a monitored bed and repeat the lactate, in 3 to 6 hours, make sure it's actually going down rather than going up. And then what is lactate clearance? And there was a study that came out in JAMA a couple of years ago by Dr. Alan Jones talking about lactate clearance. It was just as good as SCVO2. And what that basically is, if the lactate decreased by 10% over a time period of 2 to 4 hours or so, that was a sign of improvement and maybe just as good as some of the other hemodynamic markers. So normalization of lactate in the first 6 hours of treatment has been shown to associate with decreased mortality. So it is important, again, to continue to monitor your lactate. And even after you've gotten one, perhaps maybe get a lactate every 6 hours for the first day or so to make sure that the patient doesn't rebound. Next, talk about early antibiotics. And again, I just want to emphasize that even though this is in the 3-hour bundle, the guideline specifically says that antibiotics, broad-spectrum antibiotics, should be given within the first hour of recognition of septic shock or severe sepsis. So that's really the metric that we're using, and we want to monitor that. And again, this is a study by Kumar, again, just showing that in septic shock, every hour of delay in antibiotic administration was associated with a 7.6 decrease in survival. That's a number you can take back with you to talk to your colleagues about the importance of early antibiotics. Now, we're not really proposing a specific regimen, but I think it's good to have a regimen in your protocol, because sometimes these patients come in, you're in a hurry, but you're trying to figure out what is the source and trying to choose the antibiotic. For example, I haven't been able to get a chest x-ray yet. I'm not sure what antibiotic to use. It's nice to have something that's just really broad spectrum you can give right off the bat. Get the blood cultures right away, get the urine culture, and then start them on, and this is just a protocol that we use in our hospital, and it will vary depending on your susceptibility patterns, but we use piperacillin, tazobactam, and vancomycin. If there's a penicillin allergy, then meropenem. And then if community-acquired pneumonia, we'll give either azithromycin or levofloxacin. I believe we're going to have a talk later on this afternoon about antibiotics in more detail. But I think having this in your protocol will speed things up, and having a way of getting these quickly. So next I'm going to talk about the 3-hour bundle. And this has already been alluded to, but just re-emphasize again. Now, this should be done within 3 hours of the time of triage, or if the patient's on the floor, 3 hours from the time when the chart shows that this patient had evidence of sepsis. So first thing is to measure lactate, obtain blood cultures prior to administration. If you can't get blood culture for some reason, I wouldn't delay antibiotics more than about 45 minutes or so, but it's nice to be able to get cultures, and it turns out only about 30% of patients with sepsis have positive blood cultures, but it will help us in de-escalating antibiotics down the road. And then administer broad-spectrum antibiotics, usually not just one, but usually dual antibiotics. And then this is the thing that I think we fall down on, at least in our hospital, is not giving enough fluids right away. So the guideline really recommends that you give 30 cc's per kilogram as the initial bolus. Now, in the process trial that we just talked about, they got, in the first 6 hours, got 4 to 5 liters of fluid. So this is just the first initial bolus of 30 cc's per kilogram if crystallite as fast as possible. And then the transfer trigger tool. This again is part of that same algorithm that I was showing you earlier, but if we focus down on this area here, if you happen to be a hospital that doesn't have an ICU, what are the triggers that you're going to transfer this patient to another hospital with an ICU? So what we have in here, if a lactate greater than 4, or hypotension unresponsive to the 30 cc's per kilogram crystallite, or 2 or more organ dysfunctions that Sherry talked about, or progression of symptoms despite treatment. And our goal is that this should happen within 2 hours. We kind of have a golden hour for trauma transfers, or an hour, but for the transfer trigger tool, we would think that's a reasonable expectation to get these patients transferred within 2 hours. And that's something, a metric or a benchmark that I think would be a good one to measure. Now, depending on your situation, there are going to be hospitals where you're going to start the 6 hour, you're going to go beyond the 3 hour bundle, and this is our hospital. And we usually actually do most of our lines and things like that in the ED. This is just a recent septic patient we have. If you look at the guideline again regarding initial resuscitation, it says we recommend the protocolized quantitative resuscitation of patients with sepsis-induced hypoperfusion persisting after the initial fluid challenge or blood lactate greater than 4. And this protocol should be initiated as soon as hypoperfusion is recognized and should not be delayed pending ICU administration. Now that's going to vary from institution to institution. If you have a problem where patients board in your ED and they take a long time to get up to the ICU, you may need to do more of this in the ED. In our particular situation, we have a sepsis team that comes to the ED with us, and we implement a lot of these things. So these are, I'm not going to go into detail because you've seen these and you're going to see more about this, but this is the things that we will initiate in the emergency department as well. Vasopressors, and then we'll put a CVP and monitor CVP if we need to, and then remeasure lactate. So with that, I'm going to turn things over to Marcie, who's going to tell you how it's really done. So.
Well, thank you, Dr. Larson. I know Dr. Larson from a long time ago. I had stitches put in my forehead when I was a teenager, and he stitched me up. So and I'm not saying you're old, I'm just saying that he's been around and he knows the business. I'm Marcie Zabel. I was born and raised in the Carver County area. I was actually born at Ridgeview Medical Center. My husband was born there, my babies were born there. I have family members that work at Ridgeview, and I've had family members that die at Ridgeview. So it's a special place in my heart for Ridgeview, and that's why I'm just such an advocate for anything we can do to improve the health of our local area. And if it's with sepsis recognition, that's what's important to me. Like Dr. Davis from Central Care Hospital has said about his St. Cloud area, I say about Ridgeview that they're my people, and this is my corner of the world. I don't have a lot of statistics to tell you about, and I didn't use a whole lot of the slides. I'm not a speaker. I'm a bedside nurse in the ER, as I'm hoping a lot of you guys are. So I'll kind of go through what I do as a triage nurse and why I was so eager to be part of the sepsis initiative. My favorite assignment as a staff nurse in the ER is that of a triage nurse. Assessment skills, intuition, and knowledge are all combined to decide the patient's illness acuity level. They come in, with family or friends, and they've already diagnosed themselves. They think they're having a heart attack. I think I'm passing a kidney stone. Or when WebMD says I have appendicitis. More likely, a patient doesn't ever come in saying they think they're in septic shock. The family member or the patient would just say, I don't feel right, something's not right. They're not acting right, something's not right. The clock begins ticking when the patient walks into the ER. This is known as the time zero or the time of presentation. After receiving their initial complaint or primary symptoms the patient is experiencing, you get the set of vital signs. The sepsis tool that Ridgeview utilizes can be completed easily in the first 5 minutes of a patient's visit. Right now it's in paper format. This is what it looks like, according to the SIRS criteria and suspected infection. And the hardest part, I think, is to recognize what could be considered an infection. Something as simple as a cough could be a suspected infection. Upper respiratory symptoms, urinary symptoms, or weakness could be considered an infection. When we've obtained the vital signs and determined their acuity level, we use an ESI acuity level. One is the life-saving interventions are required. We have a lot of sepsis patients that come in off the street, and they're assigned acuity level 1 and have to be treated aggressively. They're usually a 2 or a 3, so if they're a 1 or 2, we'd put them in our stay room. If they're a 3, then we are able to treat them emergently, but just in an ED bed. For the sepsis algorithm, the next couple steps kind of happen simultaneously. You first alert the MD and the primary nurse of a positive sepsis screen, and then you complete the sepsis bundle to evaluate for the severe sepsis. I, as a triage nurse, would work with the primary nurse to stabilize the patient such that the first nursing interventions are completed. Large gauge IVs, preferably 18 gauge or larger, and sometimes in a clamped down septic shock patient, that itself is difficult enough. Getting labs, the all-important lactate, blood cultures, BMETA, CBC, and getting a UA, UC. We usually do a straight cath so that it's as sterile as possible. And initiating fluids. It is usually at this time that the doctor comes in and evaluates them more and will order further tests. So it really is the bedside nurse's responsibility to be very proactive and confident in their assessment skills. That's what the sepsis screen doesn't do. I mean, you can't teach a nurse how to look for some symptoms. You just have to have that gut instinct. Many times these tests are completed by the time the doctor sees them, but sometimes just getting the IV in can be a huge problem. Just a couple weeks ago on March 17th, my husband's grandmother passed away in my emergency department from septic shock as a result of pneumonia. IV was delayed due to she was just so clamped down in shock, and therefore they couldn't do the antibiotics. By the time they got the central line in, her pressure dropped, her pulse dropped, and she went apneic, and she died within a few minutes. So it's just this whole, it can last up to 36 hours, and or it can last just a few hours. This patient came in as a level 2 trauma to our ER. We have level 1 and level 2 traumas, and we follow a certain protocol for them. The trauma team protocol was followed, and the sepsis protocol was a little bit delayed due to trauma stuff. He had fallen in the shower, complaining of back and neck pain. I was actually the primary nurse for this patient. EMS was unable to start an IV, and they administered IM morphine for pain control en route. On arrival, his blood pressure was as you see there, and it was thought that this hypotension was due to the morphine IM that was administered. I had a hard time believing that because he was a chronic pain patient and he had a large tolerance for narcotics. He was backported and seat-collared, so a core temp or rectal temp was delayed. Temporally, he was 100.2, but I think the whole sepsis picture was shadowed by the trauma. He received the 2 large bore IVs. I actually got one in, and another nurse did. We sent him immediately to the CT after starting some fluids for his hypotension. He continued to be hypotensive and tachycardic, and after the CTs were cleared, the core temp was obtained, and it was 101.3. It was then that we drew a lactic acid. I actually drew it, and it was 6.4. He presented at 13:48 in the afternoon. His lactate was drawn at 15:10. Shortly thereafter, he developed worsening hypotension. A central line was inserted. He was started on Levophed, and he was transferred to an ICU in the Twin Cities. What came in as a trauma left as a severe sepsis. Falls and weakness are one of the most common incidents requiring ambulance transport. And while not only treating the injuries, determining why they fell or why they are weak should be a priority as well. As a ER nurse, one of the big things that we try to figure out right when they present is where are they going to go, because we don't want them in our ER for that long. So following the 3-hour bundle and figuring out disposition is very important too. What the MHAC and Sepsis Initiative has done is to create a roadmap to streamline sepsis care across the state. As we all know, some people don't like to follow maps. They don't like to follow instructions. Those are the naysayers. They will get lost along the way, and I think definitely with sepsis, you can get lost along the way. We look at the 3-100s, and that seems quite obvious, but as with this trauma patient, what was so obvious was actually kind of skewed. So follow the directions, and while this is okay in certain situations not to follow the directions, it is not okay when the consequences are life or death. Encourage your hospitals and staff to adopt the tools we have created for you so we can stop getting lost along the way. Create in your staff the same sense of urgency for sepsis treatment that is felt during a STEMI or acute CVA or trauma. Become the sepsis champions of your local hospitals. I know you guys are probably all local hospital areas. So become that sepsis champion.
Okay, so just a couple other things. This is, we do have a sepsis team. So when we declare that the patient has severe sepsis, we send a group page, which includes not only the ED physician and nurse, usually 2 nurses. We also include respiratory therapy, which we're fortunate to have, pharmacy, a lab technician, radiology, and then we also will page the admitting physician, ICU physician, and the ICU nurse. Where that's really been helpful, again, these patients are very complicated. First of all of a sudden, the ICU knows they have a patient coming. They send a nurse down who gets involved, who helps with some of the lines and things like that, but then it really makes the handoff go well. Now, the ICU physician may not come down and stay down there, but they may want to come down and at least see the patient before they get intubated or something like that, so they're already aware. So it's not like we're doing all this thing and then we send them up. There's a real nice handoff that goes on. And there are times when we'll page a sepsis team and we say, well, we don't really need all you people, but and we'll do the same thing up on the floor. We have a part of a rapid response team, if it's recognized. But having a sepsis team, I think, has been really valuable. And again, that also creates a sense of urgency, just like we have a stroke team, we have a trauma team. This is just one of the little reminders we have on all of the computers, just as a little, to be thinking about this. And then, like we always say, ask the question, could this be sepsis? Any patient presenting with weakness, syncope, vomiting, or confusion. And so just in summary, just kind of emphasize the key points. If you haven't done this already, develop sepsis screen tools to screen all patients for sepsis. Use lactates to screen for severe sepsis. And I think it's a really good idea to link a lactate to your blood culture. Try to create a sense of urgency within your staff and your hospitals of treating severe sepsis. Talk about it just like we talk about STEMI, stroke, and trauma. There's a lot of resources available through MHA, through the Surviving Sepsis campaign. You don't have to reinvent the wheel. All of these tools are available, and you can take them and just adopt them to your own setting. And then again, recognize occult severe sepsis and septic shock. With that, I'll just be happy to entertain questions.
So I know you were speaking about actions within the ED, and you paged this sepsis team. Do you have a team on an inpatient basis? And if you do you include the same people and just the ED doesn't respond?
We actually do, theoretically. We don't call it very often, but we do have a sepsis team for the hospital as well. So if necessary, we would even go up and help from the ED, either on the floor or in the ICU. But the real key people in the sepsis team is not only a physician nurse, but having pharmacy, which helps with antibiotics and drips, and respiratory therapy, lab and x-ray.
Thank you.
Again, I'd like to ask, where does IP fit into your whole process here, your infection preventionist? And is your IP reviewing these cases either concurrently or after the occurrence and a part of the team?
Well, that's probably one area we could do better on. We have a regular sepsis group huddle that meets. Initially, we met very frequently every few weeks, and now we meet about once a month and review this. But I think that's probably a good idea. We don't really have anybody on. I don't think we have anybody on our team, do we, Julie? No. But that's a great idea.
You talked about early transfer, but if you live in a smaller hospital where most of your patients probably are going to be transferred out, at what point, like a STEMI gets out within a certain time frame, a trauma is out within a certain time frame, is there a set kind of a thing for sepsis that we should be getting these patients in early out?
Yeah,
should we be airing them? Should we be?
Yes, I think so. I mean, our goal is a 2-hour window that they should be resuscitated and transferred, within 2 hours. Maybe in somebody who's, maybe you can even do it faster than that. But I think as we've talked about as far as our collaboration, we thought with the transfer trigger tool, we'd like to see that out within 2 hours. And I think, these patients certainly may require air transport.
How do you ensure that all your sepsis cases get reviewed? Because we've kind of had trouble getting diagnoses, like a group of them, so we make sure we're not missing any.
That is really
Dr. Larson does all of that.
Yeah, exactly. No. Actually, we Julie Burkhardt here, who's from our quality department does review all these cases retrospectively. The challenge being if it's not coded properly, it's hard to get it. So one of the things that we've taught our physicians is use the 3 codes. There's a sepsis, severe sepsis, and septic shock codes, ICD-9 codes anyway. Let me change the ICD-10. So don't use things like bacteremia or septicemia or gram-negative sepsis. And we try to review concurrently as well. We do. Now, one thing about having a sepsis team is it goes out, Julie carries a pager, so she always knows when the sepsis team is activated. So that's one way we pick up on those. Then we'll try to look at those cases concurrently. So in fact, we had a case last night, and we were just talking about it. I was asking Marcie, what was the duration of antibiotics? And it was longer than an hour because somebody was waiting for a chest x-ray. So we're going to go back and we're going to talk to that physician and the nurses and say, so I think that if you can give that feedback immediately, that's very helpful.
There's been a lot of talk about the differences in the older patient and recognizing sepsis. Is there any little pearls that you can give us about looking for sepsis in our younger patients? Are there differences in the younger patients, pediatrics especially?
Oh. Well, fortunately, pediatrics is less common, but we do see that as well. I think the younger patients do have more of an inflammatory response. They do present, I think, more with fever and that sort of thing. But other than that, what do you think?
When I do a few chart reviews in sepsis patients, I see a lot of vomiting as one of the primary complaints, and I asked Dr. Larson about that too. And I feel like that was part of maybe the younger patients that I saw, a 41-year-old, a 46-year-old recently. That was the vomiting and weakness.
Yes, I'm Dr. Nazir. I think part of my presentation later will address some of the pearls with the elderly patients.
Perfect, great.
So I'll address that.
Good.
But I have a question for you. I think if someone can address the importance of source control in the first 6 hours, I think we have not addressed that, but that's part of the guidelines. If someone has infected catheter or comes with abdominal abscess, what is the urgency in regards to the source control for these patients in the first 6 hours?
Yeah. Well, we actually have that on our checklist, and that involves usually, if it's not obvious, so we'll do some imaging, obviously a chest x-ray, but we'll do ultrasound, looking for any urinary tract obstruction. We will do, if we don't have an obvious source, they'll oftentimes get a CT of chest, abdomen, pelvis. Obviously, if you've got any lines in, those will be removed, or we'll get surgery involved in that. But yeah, that is part of our checklist as well, which we didn't really elaborate on too much.
As co-pays have gone higher and higher for a lot of our patients, in our health system, we're seeing patients go to the urgent cares rather than the emergency center or ED first. I'm just curious, has there been any plan to push out any of these kind of assessment tools or thoughts to more of your, tertiary areas so that they're all thinking the same thing and we get people care sooner?
Well, that's a great point. We, in our hospital, we do the education for not just the ED staff, but also primary care as well. So they're getting the same message about that. Our freestanding ER is also an urgent care, so we have the same protocol there. Of course, anybody comes in there, even though they're having a STEMI, they want to be urgent care, But we have the same protocol, so we have the same nurses, same doctors taking care of patients in urgent care and in the ER. So. But I think it's a great point to really disseminate this information out more broadly to primary care clinics, and they go to the primary care clinics as well, and urgent care.
Dr. Larson and Marcie, would you speak to the importance of having sepsis champions, physician champions, nursing champions, and the impact that has on our success?
So I'm known as the sepsis queen around the hospital. I don't act like this normally. I'm normally a little more outgoing. So it's easy to just at the nurses' station, just to teach one-on-one to all the nurses, and even to some of the doctors. I've been successful with them as well. So I think doing on a more an individual basis is successful. Putting up the posters, putting up the reminders, having at your work groups or wherever you do your education is important. But I think doing it individually is how you're going to capture the most the impact.
I'll just say one more thing. When we started this back, I think in 2007, I mean, we tried to first implement this into the ED and found it didn't really go very far unless we really got the hospitalists and other staff throughout the hospital involved. And so before it even took off, we had one of our hospitals who became a champion as well. And I think you really have to have that kind of collaboration. And it's not just physicians and nurses either. It's having lab. We have the director of our lab here, Dean Porter. We have respiratory therapy. We have a quality. And you really have to get all of those people on board.
So can you share with us a little bit about your results?
Yeah, Julie, maybe you can, I don't know. I think what I know, we did actually, our mortality rate, that's all I know is mortality rate, went from about, I think 7%, 38% of our baseline. And last year's mortality was around 20%, just a little over 20%, a little over 20%. And that includes, obviously we're including all of the patients who elect not to have any kind of early goal-directed therapy because they're palliative care papers. We see a lot of patients who come in from a nursing home, and then as soon as we do the initial resuscitation, the family says, well, we just want to make them comfort care, and that adds to your mortality. But we do include that in our data.
Do you have any idea what that palliative population is, what the percentage is?
Well, I'll tell you what, I think I might defer that to Dr. Davis because he's done a lot of work with that this afternoon. The palliative population.
Out of that 20%,
yeah.
what percentage of that is?
Yeah, I can tell you exactly. Yeah, I think we took that out. When we took it out, our mortality rate was like, what was it, 6%? 8%, yeah. If we did from 2013, took out the patients who elected the palliative care, it was 6% mortality.
So you've got a 14% given mortality right off the bat because they're palliative/hospice.
Right. But I think that's a really important component of your protocols as well. And I know you guys at St. Cloud have done a lot with that, so.